أنا جاي on behalf of the National Institute of Nephrology and the Bureau of Colonia, and he conveys his apologies to the audience and his professors because he's having his uncle in the hospital is very sick. Yesterday at 1 a.m. Maybe he sent me this presentation. I read it quickly in the morning. It's a pretty long one. It's about 70 slides. So I'm going to be running some of the slides, not to oversee the time. أنا بس before starting the session أنا عايز أتكلم على المحاضرة بتاعت الدكتور خالد، وعجبني فيها قوي الريسبتور 80 و86 وهي ماشية الصراحة مع قوانين العقوبات اللي هيحكم بيها البلاك بلوكس، وأتمنى إن هم يلاقوا حاجات تانية يعاقبوا بيها الوايت بلوكس. عشان كده النهارده جيت بني قلت عشان الواحد والله بيسموني عشان ما ابقاش واحد تاني. طيب بسم الله الرحمن الرحيم. Cancer after kidney transplant. Is it a myth or a reality? As the audience know, the kidney transplant is the best therapeutic option for patients with end-stage kidney disease, and it improved the survival and the quality of life for those patients. And the improved methodology and availability of more effective immunosuppression protocols increased the graft survival over the last 20 years. Of course, after the introduction of new immunosuppressions like the CNIs and mTORs and induction therapies and strategic bleeding agents. Overall, post-transplant patient survival has risen notably, with the 1-year graft survival that's rising to over 90% all over the world. There's also other organ transplants that's advancing all over the world, and unfortunately in Egypt it's not there for the lack of a cadaveric law until now, like the heart, the liver, and the lung transplants with increased survival due to modern immunosuppression. However, in the past 20 years, the long-term survival rates have changed very little. There was no dramatic or new events that improved the graft survival after the recent era. There is, in the last 5 to 10 years, post-transplant kidney failure rates and liver grafts and lungs and hearts is equally the same. Of course, the long-term complications of immunosuppression, including nephrotoxicity and cardiovascular complications and infections and malignancies, are largely responsible for this, without for the lack of long-term improvement. The transplant recipients at increased risk of developing malignancy because longer lifespan and chronic exposure to immunosuppression, and the role of immunosuppression, which is not only impair the normal immune function, but also have direct pro-oncogenic activity. Also, the long-term immune deficiency of the transplant recipients make them at risk for oncoviral infection leading to malignancy. Indeed, cancer incidence among transplant recipients is greater than in the general population. So, if we are speaking about cancer incidence with transplantations, what's the incidence? In Egypt, unfortunately, we have no clear statistics, but all over the world there's many statistics and many studies that's described in the United States, the Canadian, China, all the countries. If the incidence of malignancies in general, different malignancies by their specific types, increased after organ transplantation by a reason? Yes, because a recent large study in the United States of more than 175,000 transplants, solid organs, kidney, liver, heart, and lungs. Black box. From the US Scientific Registry of Transplant Recipients and 13 regional cancer registries noted that the overall cancer risk was elevated. More than 10,000 cases and incidence of 1,400 per 100,000 person per year with a standardized incidence ratio of 2.1. However, this is also a post-transplant cancer in Canada with more than 11,000 transplants in a combination with Canadian Organ Replacement Registry and the Canadian Cancer Registry, with a beautiful distribution of the standardized incidence ratio according to the cancer and the size and the incidence. And post-transplant cancer in the US even, there is more stratification in the skin, the gastrointestinal tract, the genitourinary, and the ratios one from Korea, a great study from Korea in 2011, which investigated the cumulative incidence of cancer at 1 year, 5 years, 10 years, 20 years, and 30 years. And if you look here, it's 0.64 in the first years, 2.5 in the second year, maybe after 5 years is 8%, after 20 years is 21%, and after 30 years is 66% respectively. Of course, the risk of Kaposi and malignant lymphoma, skin cancers, cervical cancer, and renal cell carcinoma was more than 10 times higher in the kidney recipients. So what about de novo malignancies in renal transplant recipients? This is an experience at a single center with more than 1,800 transplant recipients over 39 years, which showed that the overall risk of developing post-transplant non-skin malignancy was 12-fold higher compared with the age-matched control. So after transplantation, cancer risks varies from no increase for several common cancers and many-fold increase to number of virus-associated cancers. If you look carefully, the cancer incidence in the breast as an incidence in women is not increased. Also the prostate, but if you look carefully, also the skin and the post-transplant lymphoproliferative disorders and the genitourinary is increased pretty much than the general population, even pretty much than the end-stage kidney diseases, and this will be shown later. Overall, the most common malignancies in post-transplant settings are divided into non-melanoma skin cancer and other than skin cancers, post-transplant lymphoproliferative disorders, Kaposi carcinomas, Kaposi sarcomas, and anogenital cancer, and here the anogenital is combined together. And this is a distribution of the common post-transplant tumors in transplant recipients. It's from the liver, the renal, the heart, the lung, with the incidence due to the most common malignancies ranging from non-melanoma skin cancers, melanoma, non-Hodgkin lymphoma, Hodgkin's, Kaposi, limb, oral, etc. This is the cancer risk versus the general population. There's a definite increase, as said before, in the skin, the vulvovagina, cervix, uterus, lymphoma, liver, and kidney, and a little more increase in the breast or prostate or the colon or the lungs. In addition to the higher incidence, cancer usually progresses at a faster rate, has a worse prognosis, and is more refractory to treatment. Cancer after transplantation can be classified into a donor-driven malignancy, also cancer recurrence after transplantation, and de novo cancers. If we're going to take the donor-driven malignancy, previously donors with cancers, especially in the cadaveric settings, most instances should be an absolute contraindication to organ donation. This was set in 2002 because the transmission of the undiagnosed cancer to recipients was 1 to 1.3%. However, a recent large population study of cancer incidence from donors with cancer showed an annual cancer incidence of less than 0.2. It's not serious. In this era of organ scarcity, when demand for organs exceeds the supply, some centers use donors with cancers, such as cancers of CNS, with special criteria to reduce the mortality from the waiting list. And this is a table with the suggested risk categories for specific tumors by malignancy subcommittee for the disease transmission advisory committee, including minimal risk, low risk, intermediate risk, and high risk according to the cancer. So if you're going to look at the minimal risk, there is a basal cell carcinoma in the skin, and the high risk from the malignant melanoma. Cancer after transplantation also may be due to cancer recurrence in renal transplant recipients. So if you have a cancer, a chronic renal failure patient on dialysis that suffered malignancy before and is cured, you must have a grace period before starting to retransplant. And this grace period ranges from 2 to 5 years according to the severity of the malignancy and the type and the postulated period of recurrence. So most guidelines recommend a 2 to 5 year waiting time for candidates with successful treatment of cancer and renal transplantation. And this is when you transplant with no delay and when you wait more than 2 to 5 years, like in malignant melanomas. Cancer recurrence in renal transplant recipients also, and this is the postulated risk of the recurrence, according to low risk, intermediate recurrence, and high recurrences. Post-transplant cancer, de novo cancer. Now we spoke about the transmission of cancer from donors, the recurrence of cancer in already patients with end-stage kidney disease that had a transplant and had a recurrent cancer, and this is the de novo cancer, which actually includes most of those population of patients. The overall increase in the incidence of malignancy after transplant is mainly due to de novo cancers and lymphomas. This phenomenon is not affecting types of tumors equally, but rather show a predominance of certain malignancies. If we see here, the colon, prostate, and breast cancers exhibit a modest increase during the first year. However, the non-melanoma cancer of skin, which is a rare tumor, is an 84-fold increase. However, also the kidney cancer is 42-fold, and the uterine cancer is 74-fold. However, the skin cancer, also among transplant recipients below 35 years, was found to be 2% of renal transplant recipients, comprising 10-fold increase. Non-melanoma skin cancer in solid organ transplant recipients are 250 times more likely to develop more non-melanoma skin cancer, mainly squamous cell carcinoma and basal cell carcinoma. And of course here, the punched out edges as seen in the pathology of the basal cell and the squamous cell part. Here also some pictures of the squamous cell carcinoma, basal cell carcinoma, and the keratoacanthoma that may be mistaken with the basal cell carcinoma or the Kaposi sarcoma, and this is also a basal cell carcinoma and the keratoacanthoma. The PTLD or lymphoma post-renal transplant is a heterogeneous group, and it's mainly related to the Epstein-Barr virus mostly, and this is a picture of the Burkitt cell lymphoma and also the nasopharyngeal carcinoma, Morph lymphoma, lymphoproliferative disease, and oral hairy cell leukemia. All these are associated with the Epstein-Barr virus, either infection or reactivation of infection. So the PTLD lymphoma is mainly associated with EBV infection, either through an EBV seronegative recipients who had a seropositive graft, or PTLD occurrence also on the type of organ transplant, with intestinal transplantation having the highest rate, followed by the heart, lung, liver, and least the kidney. There is a close relationship between immunosuppression dose, intensity, and PTLD incidence. Patients who are heavily immunosuppressed are at increased risk of developing PLD. Of course, the role of T-cell depleting antibodies like OCT3 or ATG or thymoglobulin has a role. Treatment with CNIs like cyclosporin and FK has a role. Also, recently, the approved belatacept with co-stimulatory blockade had increased incidence of PTLD involving the CNS. However, these are pictures of Kaposi sarcoma, either cutaneous or visceral. Also, the risk of Kaposi sarcoma is increased 500-fold in solid organ transplant recipients compared with the general population, and represents about 4% of all post-transplant cases. Kaposi sarcoma is an angioproliferative neoplasm. When the cause is, of course, the herpes virus type 8. Two mechanisms have been described: the co-contamination from the donor organ or reactivation in recipients with seropositive with herpes type 8. Because the course of Kaposi sarcoma depends on the level of immunosuppression, the treatment cornerstone is to decrease immunosuppression. Of course, many other strategies like radiation and chemotherapy is used. However, recently, mTORs, PSIs, sirolimus have revolutionized the treatment of this type of cancer. Regarding the anogenital cancers, transplant recipients have an increased incidence of tumors of the anogenital region, including the anus, the vulva, the perianal region, penis, scrotum, and the perineum. They are most frequently reported in women, and infection with human papillomavirus, history of genital herpes, the presence of skin cancers, and the high level of immunosuppression is a cause. Of course, the human papillomavirus is the most frequent infection in transplant recipients, and some studies from the Western populations includes 50% after 5 years is infected with the human papillomavirus. The renal cancers, which are small asymptomatic renal masses that are low-grade and low-stage tumors with a favorable prognosis, mandates follow-up for native kidneys after transplants with ultrasounds or CTs to exclude de novo malignancies in the renal. So what's really the risk factor for the tumor development? The causes of post-transplant malignancy are multifactorial. The oncogenic viruses, or integration of the viruses in the DNA of the patient, oncogenic effect of immunosuppression and the long-term use or chronic use, chronic immunosuppressive therapy having a large role, and the correlation between the length of exposure and the intensity of immunosuppression with the incidence of cancer. Here, the diagram for the post-transplant malignancy and the incidence, of course, the immunosuppression, duration, intensity, and type. Of course, with increasing age, the malignancy generally increases. Previous exposure to carcinogens and history of malignancy, chronic viral infections, and general genetic predisposition, plus the ultraviolet ray in the skin. This is a graph showing the overall, there are a number of tumors that appears to be more common in transplant population compared to the waiting list. Compared to the waiting list of patients in the end-stage kidney disease, including the skin, melanoma, mouth, esophagus, Kaposi, kidney, and lymphoma. So this is a comparison with the waiting list. So what's the cancer risk in sex? Here, according to this, women are more lucky than men. So if you look at the non-skin and the skin in men, the prevalence of skin malignancies in transplant recipients is more than women. So the cancer risk also increases with age, and the type of malignancy is different. If you compare here the age from 0 to 17 for the non-skin cancers, and here the skin cancer is different, so it increases. And if you increase here for the age more than 65, it's more even, of course, than less in this category. So what's the cancer risk with the ethnicity? And this is developed in the United States because they have multiple ethnicities. You can see here the ethnicity between white, blacks, Asians, Hispanics, and non-Hispanics, and the comparison between skin and non-skin, and you show diverse comparison between both. So what's the cumulative risk of diagnosis of cancer after renal transplant? So with the increasing time of transplant, you can see the curve going up through all types of cancer with different penetration. So any cancer increases overall, the skin cancer increases dramatically, and here below you have the age-band control. So what's the cancer risk with the cigarette smoking? Of course, previous history of cigarette smoking will increase this risk. And here are some of the tumor viruses that leads to malignancy post-renal transplant, including, of course, the herpes type, herpes family, the hepatitis B and C, especially in Egypt, showing cerebral carcinoma, and human papillomavirus showing cervical carcinoma and non-melanoma skin cancer, plus some studies showing baby virus, GC virus, and SV40 virus, including mesothelioma, brain tumors, and Merkel cell, of course, and Helicobacter tumors and gastric mold lymphomas. So what's the viral strategies to cause tumors? There's some strategies to virus that increase the oncogenic, and some of these factors also increase. For increasing the malignancies, they suppress the viral oncoproteins, activate cellular oncogenes, and by inhibiting also apoptosis and the immune evasion and inactivating tumor suppressive genes, also this may decrease the malignancies. So what's the impact of immunosuppression agents on cancer risk? Of course, when you all immunosuppression except the mTORs may lead to malignancies, and we have here a very good table showing this. So the assessment of epidemiological, diagnostic, and risk factors associated with the development of post-transplant malignancies, management strategies for decreasing the recurrence of pre-transplant malignancies, and the minimization of malignancies transmissions from the donor organs. So this is the cyclosporin and aprolimus, which both increase the cancer risk, and the treatment strategy will rely on withdrawal or reduction. Here, of course, the OPT3 and the ATG, which of course increase the risk, especially the TLD, azathioprine, which may increase the MMF, which may reduce to the potential anti-oncogenic, anti-proliferative role, and the PXI, which is used as a treatment for this problem. And this is a table showing the impact of immunosuppressive agents on the risk of post-transplant malignancies. According to type, induction therapy, antimetabolites, CNIs, PSIs. And here is a schematic diagram showing the mechanism, how the potential mechanism by which immunosuppression contribute to tumor growth after transplantation. If you look here, the viral replication, angiogenesis, and tumor invasion, and mutagenesis leading to tumor growth, and which type of immunosuppression leading to this. If you look here for the CNI, leading to viral replication, angiogenesis, and tumor invasion, and the T-cell body depleting agents which lead to viral replication, and azathioprine, which may lead to mutagenesis. And this is another one showing the role of inhibition of the immunosuppression to the interleukin-6 tumor growth factor beta and vascular endothelial growth factor with the interference and tumor invasion and metastasis and Epstein-Barr-induced beta cell growth. So reduction in immunosuppression, conversion from CNIs to mTOR inhibitors, and inclusion of mTOR inhibitors in CNI-based immunosuppressive regimens are some of the strategies recommended upon diagnosis. However, mTOR inhibitors are the first class of suppressants to be associated with long-term, with a significant decrease in post-transplant de novo malignancies, and can be recommended as a cornerstone immunosuppression for patients who had a pre-transplant malignancy or developed de novo cancer post-transplant. This is the study for sirolimus and secondary skin cancer prevention of kidney transplant, and also this is an incidence of skin cancers. So, concluding, switching from CNIs inhibitors to sirolimus or everolimus has an anti-tumoral effect among kidney transplant recipients with previous squamous cell carcinoma. These observations may have implication concerning immunosuppressive treatment of patients with cutaneous squamous cell carcinoma. This is the CONVERT study comparing how malignancies was less with the sirolimus against the CNI, and this is how the strategies according to either steroid minimization or CNI minimization or withdrawal with the use of mTORs. And also this is the table showing the reduced incidence of de novo malignancies with PSI compared with CNI containing regimens. This is the proliferation signal inhibitors or mTORs, PSI, sirolimus, and everolimus, and we already, this is the results of the CONVERT study of early versus late conversion or withdrawal of CNIs or minimization. And this is a picture for patients converted from to sirolimus with successful treatment for post-transplant Kaposi sarcoma. So with viral infection, new angiogenesis, cell proliferation, and cell differentiation because of de novo malignancies in transplants, and decreased viral infection in everolimus treated hard transplant recipients was treated here, also giving another impact about the mTORs and decreasing the viral infections which are implicated in the development of malignancies post-transplant. This is how sirolimus affects on tumor growth, the anti-angiogenic effect, and the involvement of the vascular endothelial growth factor. And this is the proliferation state. Human papilloma HHV8 produces receptors that promote the proliferation of endothelial cells by the activation of FA1 of the vascular endothelium. And this is a strategy for how you manage renal transplant recipient with diagnosed cancer. So if you assess the prognosis of cancer first, and Kaposi sarcoma, if you assess the prognosis of cancer and you have renal function and proteinuria or not, so you assess the prognosis of cancer and you assess your graft. If you have a poor prognosis and disseminate disease, don't interfere. Maintain the graft because this may be beneficial for the chemotherapy. Of course, chemotherapy, many chemotherapeutic agents needs normal creatinine. And if you have not poor prognosis and the GFR of the kidney is more than 40 ml per minute and the proteinuria is less than 800, you can start the PSI or stop or reduce CNI judiciously, and you can increase the dose of the PSI accordingly as a treatment strategy for the cancer, and you can minimize the elotherapine or shift to the MMF dose and maintain steroids. If you have a Kaposi sarcoma, it's different. You start PSI differently. You stop the CNI, you minimize the anti-metabolites and maintain steroids, and you monitor the disease. If the poor prognosis, consider high-dose PSIs. So lastly, the conclusions and recommendations. Recipients of the transplant are at increased risk of developing infection-related and unrelated to post-transplant malignancies. Oncovirus such as Epstein-Barr human papilloma virus play a significant role in the development of post-transplant malignancies. It's important to detect malignancies in the donor organs. However, not all malignancies constitute an absolute contraindication to donation. To reduce and effectively manage post-transplant malignancies, active monitoring and follow-up of patients are essential. Viral infection control, particularly important in patients who develop a primary viral infection and in chronic carriers of Epstein-Barr, human papillomavirus, hepatitis B, hepatitis C, and herpes type 8, the screening of Epstein-Barr virus load, and the introduction of prophylactic antiviral therapy against Epstein-Barr have shown to be significantly reduced PTLD-related mortality, immunosuppression modulation, reduction in immunosuppression, conversion from CNIs to mTORs, inclusion of mTOR inhibitor in a CNI-based immunosuppressive regimen is of help. Also, mTOR inhibitors are the first class of immunosuppressants to be associated in the long term with significant decrease in post-transplant de novo malignancies and can be recommended as a cornerstone immunosuppression for renal transplant recipients who had a pre-transplant malignancy or developed de novo cancer post-transplant. Thank you very much for your listening. And I hope that the presentation is okay. I just won't hear it in the morning.
بروفيسور جمال اتفضل يا فندم.
اشكرك الاول على البرزنتيشن حاجه كتير ساعتين يعني.
الله يسعدك يا صبحي. لا دكتور عاشور كلمني الساعه 1 بالليل اللي يعملها.
احييك على البرزنتيشن الرائعه. هو في بوينتس هقولهم بسرعه. احنا حضرتك تذكر تصدي واحنا كنا بنجمع التوتال نمبر اوف ريجستر كيسز في ايجيبت في ديفرنت سنترز في 2011 جمعنا من التنظيم والدكتور والسؤال. And we need the new data of 2012 in different centers. بس كنا سنة بناخد التوتال كولكتيف نمبر. والدكتور السيسي دلوقتي شيت كبير وكنت لسه بتكلم مع الدكتورة سامي والدكتورة غالي ان احنا فول اب كيسز ان اور كلينكس وي دونت ريكول PTLD at all ما بنشوفهاش. يعني لو حد سنتر مثلا الدكتورة بابا عارف تشوف القصر العيني ودونت انكاونتر PTLD ما اعرفش على حضرتك تشوفه ولا لا اتس نيل. فدي احنا ممكن من واحنا بنعمل الريجستر التوتال يا ريت بس لو حد كان شاف حاله PTLD واحده يقول لي عليها او هاتوا سيلر كارسينوما واحنا عندنا HCD اعلى من اي دوله في العالم وما بنشوفش فيها سيلر كارسينوما كتير. انا ما شفتهاش عندنا.
انا يعني
لو عندك حاله بليز
احنا وي ار انترناشونال انستيتيوت
وهنجمع الداتا ديت وممكن ننشرها كومباريزون مع اللينكس بتاعت اسبانيا واستراليا كانسيدنس اوف PTLD وهيباتيك كارسينوما ان ايجيبت خلال اللاست ريجستري اللي عندنا زي فول اب كيس.
الاهم من اننا ننشرها ان احنا نحاول نعرف السبب ايه.
احنا ما عندناش اسم.
يعني ما احنا بقول لك نحاول نعرف ليه احنا ما عندناش
ازاي دايما الهيباتيك سي عالي جدا.
بجد
وما بنشوفش PTLD
بالظبط.
الكومنت الثاني وبعدين هسمع النهارده اذكر حاله احب اقولها ان one of the cases الاطفال كانوا اهل ابتدوا يتضاروا مين اللي اتجرعوا. فابوه وعمامه وخلاله المهم في النهايه كان في حاجات في النهايه عمه اللي هو كان حوالي 45 سنه هو اللي صمم هو اللي اتجرعه. كان كل حاجه كويسه كان لقوا بس سيمبل سيست في الورم الجديد يعني خلاص هي دي اللي بتاخدها. بعد ما حطوها وزرعوها الدكتور شباب هو بيحس عليها كده لا دي مش سيست. فطلعت بعد كده لوكال كارسينوما عملوا لها اكسجين كونسبورت وشفت الاميتون والتشايلد دلوقتي 2.5 years ونورمال without any recurrence. فده يعني اي لايك تو منشن ما هو الدولار هو السيف يعني شوف ربنا يعني هو باي شانس هو اكسايد يعني عشان يبقى
يعني is it ethical or scientific انك انت بتعمل
احنا كنا عارفين اسيست يا بيه
ما خلاص بقى انت عارف انت بتقول الجراح قبل ما يزرعها حسس عليها.
لا بعد ما
يزرعها حسس عليها
يعني ايه مثلا
احنا كنا فاهمين انها اسيست.
ايوه يعني كونتيبل
بعد ما وصل الارض
كونتيبل يعني كويس is it ethical or
ما هو كان
مش اقصد يعني
كان قدامنا ان احنا لو شكينا نشيلها ونعمل وبعدين نفركتومايز. فاحنا قلنا خلاص نجيب ذا تشايلد الشانس ونشوف نعمل.
وبعدين انت ما عندكش كورونا حضرتك ما عندكش
كورونا بايوبسي
اخدناها عملنا السايز
السايز
اللي هي
what you believe for the causes
هو عمل زي نيفرون سبيرنج استراتيجي لمالجنسي بس وزرعوه يعني زي بالظبط ما يكون في سمول مالجنسي في الكدني وعملوا نيفرون سبيرنج استراتيجي عملوا لوكال اكسجين ما فيري سموك زي مثلا كان بوزنيك 1 ولا بوزنيك 2 فقالوا ازرع عادي بوزنيك 1 ولا 2 مش مشكله. بعد كده عمل نيفرون سبيرنج استراتيجي وعمل انفيوريشن للتيومر وهو مش عارف ان هو تيومر لسه هو عارف ليتر بالباثولوجي فما تقدرش
بعد كده يعني حرش فري فاحنا يعني لو قلنا بعد اسبوع طب هنشيل الكدني دي ولا ايه؟ بعد ما قالوا لنا دي قالوا لا ده اتش 3 وفولو
تجربه جميله.
بالنسبه للبي تي ال دي حضرتك احنا maybe we are lucky in the National Institute of Urology and Nephrology ان احنا عندنا عيانين بقالهم 20 و 30 years on follow up. Mostly not transplanted in the National Institute. We have about 850 cases transplanted in the institute, but many patients are dispensing the drugs from our institute. فاحنا عندنا حوالي 1500 عيان بيتابعوا. فبما ان العيانين ليهم قرارات على نفقه الدوله بيتحجزوا عندنا لما يتعبوا على القرار. فاحنا بنشوف الحالات زي كده مش كتير بس بنشوفها، واعتقد ان احنا عندنا ميس دايجنوسيس لحالات كتير. يعني اعتقد ان هقول لحضرتك يعني احنا مثلا عندنا خلال ال5 سنين اللي فاتوا 4-5 حالات انتستينال ليمفوما. خلاص عندنا 3 حالات سيريبرال كارسينوما. معظمهم زارعين من زمان من الناس اللي زارعين. يعني مثلا في حاله منهم مشهوره قوي اخو مدير الصيانه عندنا. ده الاستراتيجي بتاعه المعهد اول ما انشئ كان تعيين اهالي الدونرز الريليتد دونرز لاهاليهم، فكنا بنعينهم في وظائف. فالرئيس الصيانه عندنا اخوه زارع كويس. زرع بقى 30 سنه، زرع اول زرع على الاقل قعد 20 سنه وثاني زرع بقى 10 سنين. ده هيباتوسيرال كارسينوما هو اتش سي في وجاله هيباتوسيرال كارسينوما وعمل كيمو امبولايزيشن.
كونكت الداتا
اوف كورس. وعندنا 4-5 حالات بي تي ال دي انتستينال وماتوا كلهم للاسف لان احنا شخصناهم متاخر. المشكله الكبيره كمان ان الفولو اب في البوست ترانسبلانت بيريدز ان احنا بعد اول 3 شهور وي دونت اكزامين بيشنتس سواء في البرايفت سيكتور او في الجفرمنتال سيكتور، لان احنا بنعتبر ان احنا بنبص على الكرياتينين والسي بي سي والدراج ليفلز كويسه والعيان الدكتور بتاعه كويس خلاص، لكن ما فيش حد بيكزامن السكين مثلا. لكن للاسف احنا بيجي لنا ساعات ستات بالذات يقول لك اصل انا عندي حاجه. فاحنا شفنا كابوسي ساركوما كتير جدا خلاص، وبيزل سيل كارسينوما وسكويمس سيل كارسينوما كتير، بي تي ال دي 5-6 حالات انتستينال كارسينوما انتستينال ليمفوما، واحده سيريبرال ليمفوما واثنين او 3 في الثلاث سنين دول. عندنا اعتقد عندنا الحقيقه الحاجات دي كلها اتشخصت عشان ابقى اونست في ليت ستيجز فيري ليت ستيجز، ومعظم الحالات ماتت يا اما بيموت وما كانش في بوسيبيليتي ان احنا نعمل كونفرجن للرقميون مثلا او للفرولوس، لان العيان غالبا كان عنده كرونيك البريث نفروباثي او عنده بروتينوريا او كرياتين 3 مثلا. فده دول بما ان احنا عندنا عدد كبير من المرضى
في
My common sense answer would be yes, but for whom you will screen and have.
Well, generally speaking, disregarding renal transplants or kidney failure, screening for malignancies is recommended in 2 types of malignancies: prostate and breast. And some certain populations, the Japanese, for GIT cancers, عشان عندهم الانسيدنس عالية. لكن otherwise, screening for malignancies in the general population is not recommended. Up to my knowledge, there is no guidelines or recommendations for screening stations post-transplant for malignancy till this moment, for my knowledge. Regarding renal failure patients and the incidence of malignancies, which is already increased from about 10 to 30 folds in the general population, I don't think that it is cost-effective. And I think that we must follow up them as the general population, especially that the survival is the survival is not too long. What you expect from a renal failure patient to survive 30 years, this is very rare. Except if you have a patient that is young, that is on dialysis, that has a renal transplant, back on dialysis, it's about 20 or 30 years of follow-up, and you have some alarm symptoms, you go through. Of course, you have alarm symptoms, you go through diet at the general population.
If you have patient, have polycystic kidney disease, have
polycystic kidney disease is another story. Polycystic kidney disease is another story because you monitor those patients on dialysis or after renal transplants, even if you didn't nephrectomize after renal transplant, because the incidence of malignancy is pretty increased. And there are some guidelines, some recommendations that you would give them inputs. Thank you very much.
Thank you very much.